All right, so let's get going. So tonight we'll talk about labor and delivery. We'll start with kind of the normal process, what you go through. I'll tell you some things because I know there is a lot of reading with labor and delivery. So we'll talk about some of the things for you to focus on more, and some of them be like, maybe not so much. And then we'll go into kind of the abnormal, the problems that can happen with labor and delivery. All right, so how aren't you working? Oh no, is my clicker not working? Oh no. All righty, wonder if it just died. All right, manual it is. All right, so when we're talking about settings for childbirth, and again, you don't need to know the specifics of the different settings, but it's good to see that not everybody gives birth in a hospital. There's kind of three main areas. There's hospitals and homes, but there's also freestanding birth centers, and that's what you see on the picture. So they're designed to feel very much like having a home birth, but with a little bit more medical if you need it. If you're super high risk, you're not going to be able to give birth here because you're not going to have like a NICU team and things like that. But if you are relatively low risk, but you just don't want to have it at home where you're going to create a mess and all this stuff, it kind of bridges both avenues. There's a couple of them in Richmond. Don't ask me where they are. I have no idea. But I know there are a couple, but it's kind of like that middle of the road option that some people like to use. I think it's mostly midwives. Doctors may be able to use it, but I've always heard of midwives using those. All right, so let's talk about what contractions mean. So when we're talking about the parts of labor, there's the 5 Ps we're talking about, not the 5 Ps you learned in med surg, like pain, pulse, paralysis. We're not talking about those. These are factors that either can make labor progress or can halt labor and make it not progress well. So the powers is one of them. We'll also talk about the passenger and the passageway, which is the birth canal and the fetus. We'll talk about psyche. You know, mom's mental status can affect her progression with birth, and then positioning. So when we're talking about powers, this is the power that's pushing baby out. And there's 2 kind of broad categories they fit in. They can be voluntary or involuntary. That's one way to look at it, or primary and secondary. So primary is your involuntary one. So this is where your uterus is contracting. You can't control that, pushing baby down, causing the cervix to dilate in the face. And then your secondary are the ones you can control, where mama's ready to go and she's actually actively pushing on that baby to push baby out. So they work together. If one of those is disrupted, it can cause problems. And we'll talk about how the 5 Ps can cause labor problems just as much as they can cause labor to progress. So let's talk about what some of these terms mean. And this picture is in your book on page 127 if you want to look at it more closely, if you like to see a pictorial visual. So when we're talking about dilation and effacement, most people have heard of dilation, but maybe not effacement. So dilation is how big the hole gets. 10 centimeters is where you're fully dilated. So from 0 to 10, how big that hole gets on the cervix. Exactly. Yep, I got it on the next page. I'll say I think I did put that picture. Yep. The bagel. Not that I didn't give out enough food references the first week. The bagel. So it's how big the hole gets. Effacement is, as that hole gets bigger, the cervix is kind of thinning out. The best way I could describe it is, think of like when you eat a Lifesavers, the hard Lifesavers. When you suck on a Lifesaver, as that hole in the middle is getting bigger, the Lifesaver itself is getting thinner and thinner. So it's kind of similar the same way. As that cervix or that Lifesaver is getting thinner and thinner, the hole in the middle is getting bigger and bigger. So these 2 work together to make a hole big enough for baby to come through, hopefully. So when we talk about dilation, fully dilated is 10 centimeters, 0 to 10. When we talk about effacement, we talk about it in percentage. So 100% effaced is completely thinned out all the way. And usually effacement comes first. So you might be 100% effaced, but only be 6 centimeters dilated or something. And that's normal. That's okay. It thins before it starts to spread open. So we're not really going to talk about the phases of increment, peak, decrement, blah, 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 blah. The biggest thing I want you to know is frequency and duration when it comes to analyzing contractions. So frequency is how often it happens. So from the start, does everybody have this? I don't want to erase my artwork. I'll admit I write a lot for this one, this day's class. All right. So when we're talking about frequency versus duration, frequency is how often they're happening. So from the beginning of one to the beginning of the next one. It's just like when you measure a heartbeat. When you're counting a pulse rate, it's from the beginning of one pulse to the beginning of the next one. So this is how often they're happening. That's not what I meant to write. Exactly, exactly. So that's how many minutes apart. Like you say, 2 minutes apart, 5 minutes apart, 10 minutes apart. So we measure that in minutes, and that's how often they're happening. Duration is how long one contraction lasts. So from the beginning of one to the end of the same one is duration. So how long one single contraction lasts, and this is measured in seconds. So duration is from the beginning of one contraction to the beginning of the very next one. And that is set in minutes. And then duration is how long it lasts at the beginning to the end of the same one. And that we measure in seconds. So you might hear that they're having contractions every 5 minutes apart that are lasting 60 seconds, for example.
And the quicker they come, that means that they're actually going into like labor, right?
Yep.
Because they could be like long minutes, and that means that it's not that big of a deal.
Exactly. And if it's true labor, you'll see it progressively getting closer together. And generally, they recommend once you get to 5 minutes apart is when you should get to the hospital if your membranes haven't ruptured yet. Right, exactly. Exactly. I did peds clinical at Chippenham on Saturday, and there was a mom there who was obviously in labor, and she refused to go to L&D, and we're just like, oh my God, sit down. I mean, I understood her kid was going to get discharged that afternoon, and she wanted to go to VCU because that's where her doctor was. So, I mean, I get it, but sit your butt down then. She was wanting to walk all around, and oh. The 5 Ps? Yeah, we're going to go through all of them. So this is the first one, the powers. And you don't have to memorize, what are the 5 Ps? Select all that apply. It's not going to be like that. Promise. Promise. I mean, unless you want me to, you know. You know, the good thing about ATI is I can put unlimited number of answer selections. Don't do that. You don't want like A through M? Select all that apply? That would be awful. I would never. I never put more than 5 options, and usually it's 4.
So which one does the shortening of the cervix go under? Effacement?
Effacement, yes. Yes, that's exactly it. When you hear them talking about the shortening, I was talking more of it thinning out, but yes, that's exactly what it's doing. Yep. In fact, yes, I have the picture on the next slide. So if you look at, I'll turn the light off just so you can see it better. The picture that's on the left-hand side, that's what it's showing you, is that dilation and effacement. So that's what she's talking about, shortening. You see how up here it's kind of thick, it gets thinner and thinner. And then by the time you get here, it's thinned out really thin, and the hole is much bigger than it is up here. So the dilation is the bagel. And then the effacement is where it's thinning out.
So can you have one without the other?
Not usually. I don't think so. I've never heard of that. Well, you can have effacement without sometimes you'll get the effacement without the dilation, but not the dilation without the effacement. Good question. It depends. There can be different factors that are causing that. Sometimes your body's just not ready yet. Sometimes it is like you may start into labor and then it stops. There's a lot of factors that can go into it. So it just depends on the mom. And didn't progress. Right. And you see that sometimes, like you say, you might go a little bit and then everything just stops. Hey, I wouldn't have been sad about that C-section either. Right. And if you want to refer back to this picture, the one that's on the left that shows the dilation and the dilation and effacement, that's on 126 in your book as well. The same picture. Lord. Right. Exactly. And labor and delivery nurses are good. They can use their fingers and based on how far their fingers are spread out, measure and figure out how centimeters dilated you are. And I don't do that enough to tell you. If your fingers are together, that's 2 centimeters. I can tell you that much because your fingers are typically about 1 centimeter wide. If you ever need a down and dirty way to kind of figure out how to measure and you don't need exact measurements, from the tip of your finger to your first knuckle is approximately 1 inch. And then the width of your index finger is approximately 1 centimeter. So if you need approximate measurements, it helps you kind of get a quick estimate. Yes, ma'am.
Sometimes they put this like metal and it's like a tongue.
Oh.
No,
I know I always call them tongs too. I'm trying to think of a technical name for it. I've got a picture of them up here.
Yeah.
Forceps. Forceps.
What is this for? Pelvic exam.
Oh, the speculum. Is it just to open it up so you can get a better visualization? Yep. Yeah, they're ready. Yep. They got to get a good view. Do they? Yeah. Oh, yeah. I'm sure they do. Oh, yeah. You get to check lots of cervix. I'm sure it's on the job training where you're checking cervixes all day to see how large they've dilated. All right. So I will tell you, so the second P is the passage. It just means the birth canal. I do not want you to focus on the specifics of the passage. We are not going to talk about the different types of bony configurations and all that mess. We are not worried about it. But depending on the woman's shape of her pelvis, it can affect the progression of labor. There's like 5 or 6 different typical shapes. Most women have a certain shape. Most men have a certain shape. But sometimes if it's not within that most common shape, it can cause problems with delayed labor. And they can also get problems with cervical tearing and vaginal tearing and things like that. So I don't want you to focus on that passageway and how that works. Yeah, it's just the structure. It's the birth canal. So if there's problems with the birth canal, you can certainly have where it won't progress either. The one thing I do want you to know about this, and we'll talk about it again, is something called station. S-T-A-T-I-O-N, like a train station. And that's what that picture is showing right here. So, what's that?
So when we give birth, like natural, like vaginal birth, the pelvis like have fractures or not?
No, not usually. Those are pretty strong bones. It takes a lot of force to break these bones, like car accidents kind of things to break these bones. So
That's why women have wider
Yep.
pelvises, so they can.
yeah, and theirs are more rounder versus men's are almost like this heart-shaped type of pelvis. And so this picture right here is station, and all station is how far down baby has progressed. So if you look here, there's numbers. And of course, from the outside, we can't see the ischial spines, this part of the pelvic bone, but we're measuring from there to describe how far down they are. So when we're describing negative numbers, that's where baby's higher up. So if they're -2, -3, they're that many negative centimeters above those ischial spines. So that means they're farther away from where they need to be. The negative numbers are farther up, farther away. So, and it's done in centimeters. So they're -1, which means they're 1 centimeter above the ischial spines, etc.
So when you're going to do that part of the spine, are you going at the bottom of it, the top of it, the middle of it?
Typically, so we're not doing X-rays to see. It's right at this mid part. So as far as how you're assessing the mom with what you can see, it's at the level of the cervix. So when you're checking the cervix, it's the equivalent of at this 0. Yep, exactly. When we're doing positive numbers, that means you are positively coming. So when I was in school, they taught us +4 hit the floor, because once you get to +4, there's no backing out. So positive numbers, you're coming down. You might see just like the top of the head where it's hitting up against the cervix, but you wouldn't actually see.
I guess only like an X-ray you can actually see.
You would be, if the cervix, if the cervix is dilated enough, you'd probably be able to put your fingers up there and feel, but negative, they're not as worried about where they're at. But yeah, if they did an X-ray, they'd be able to see it, or even, I don't know, I would say maybe ultrasound, but I don't think ultrasound would show it correctly. So really, out of that whole thing, the only thing I want you to know is what station is. Yep, exactly. Negative is farther away, positive is closer to the destination. Yeah. That's right. Hopefully not, because you're going to have somebody catching that. But and then the other one, the passenger, is what is passing through the birth canal. So we think of obviously the fetus, but the placenta is a passenger as well. Your book goes into all the fetal positioning, right sacral anterior, left posterior. And I will tell you, if you come back to the ADN program, which I'm sure all of you will, and you have me again, you will have to analyze that and figure out what position baby is in based on your Leopold maneuvers. But for us, you ain't got to worry about that. We don't go in that depth with fetal positioning. So when we're looking at it, the reason we use fetal positioning mostly as nurses in L&D is so you can figure out where to put that external fetal monitor is. So when you're feeling for those baby parts, you can feel and see, oh, your back's right here. This is a good place to put that heart rate monitor so that we can listen to it most effectively. There's two kind of lies that you see in the picture. So longitudinal is where they're up and down. That's best. They're not coming out in transverse lie. If you look, baby is laying sideways. That's not happening, no matter how you configure it, until they try to turn her. So when, they'll do, there's something, if you've never seen it, there's something called a version, where they actually use their hands on the outside of the body, and they can, from what I understand, it's very uncomfortable. And I use uncomfortable loosely. I hear more of the word painful and horrible used, but sometimes it works, sometimes it doesn't. Ideally, they're going to try and turn them as well. I mean, can babies be birthed that way? Is it not a good idea? Either way, it's just sometimes they won't fit right coming butt first or feet first.
Yeah, I don't think so. It's a good idea to push it.
Yeah, usually they're not going to try that. Yeah. And once you get but so far along, usually if they can't flip baby by 36 or 37 weeks, it gets so tight in the uterus because baby's getting bigger that it makes it a lot more difficult. So when you see the word Leopold maneuvers, you probably saw it when you were reading. That just means where you're feeling for the certain body parts. You know, you feel the fundus to feel what's up here, and you're not going to need to demonstrate how to do that or even lay out first you do here, then you do here. But just so you know what the term is, Leopold maneuvers is where you're feeling in the abdomen to figure out how baby's positioned.
So then, in the transverse, like we should go to C-section.
Oh yeah, baby ain't coming out that way. Ain't happening. No ifs, ands, or buts about it. Not to, no pun intended.
So in the old ages, like years ago, before they used to have a midwife, what they would do in this case?
Baby would probably die. Before C-sections were invented and things like that, baby would probably die. Unless they were able to turn them so they could come out. We have advanced a lot in OB. Absolutely. So one of the symptoms of, so we talked about term being 38 to 42 weeks. 42 weeks, the placenta starts to break down. And when the placenta is breaking down, baby's not getting oxygenated. So you'll start seeing like that meconium amniotic fluid because they're in distress. They're not getting oxygenated well. So absolutely, they can be in there too long. I don't know of any doctors that are going to let you get to 42 weeks. Usually at 40, they're already being like, when can we schedule you? Maybe.
Wait, I have a question about that.
Yeah.
So, some cultures or some women, don't they prefer to have all natural, like they don't want to be induced, they don't want
Absolutely.
to be so like they are knowingly taking that risk at 42 weeks that
Yeah.
the baby might not survive.
Yeah. And that's one of the things with OB, sometimes all you can do is educate. You can't be like, I'm going to strap you down and do a C-section whether you like it or not. Right.
Yeah, and like it happens a lot. Like sometimes you see they are both dead, the mother and the baby.
Right.
Because they'd rather have a natural birth.
Right. Yeah.
And it's so sad.
Absolutely. So one of our other P's, and we're not going to go into details of this one, is called Psyche. So this is just talking about her mental status. Obviously, whatever her mental health is going into labor is going to affect her labor. So, for example, if you are giving birth and you're going to have a very different scenario of a mom, say, who is potentially, as far as she knows, having a live, healthy birth versus a mom who knows that baby has already passed away, that can actually impair their ability to progress with their labor because of that psyche. If they don't have a lot of support people, you know, if they're alone, if they have a bad home life, if they have, if they're going through something, maybe they just had a death in the family or, you know, something like that, any of those factors can affect their ability to progress and even affect the severity of their pain. It can make their pain much more worse just by any factors that are going on. So, what's that? Not at all. Not at all. Oh. So when we're talking about impending labor, so how do we know if it's true or false? So the real distinct way is to check their cervix. If their cervix isn't dilating, they're not progressing or they're not in real labor. But you can't really tell a mom when they call and ask if they're in real labor, hey, check your cervix, let's see. Tell me what you see. So they have to go by what symptoms they're having. So a couple of things like we talked about on the quiz, they have to have their contractions are going to be regular. You can time them. Okay, every 5 minutes you're having a contraction or pretty close to it. And they're also going to not improve with any kind of activity. So whether you rest, whether you walk, they're going to get worse versus false labor. They could rest and walking could both make them better. So supposedly you can. Braxton Hicks are a painless tightening of the abdomen, but I will tell you, when I had mine, they were not always painless. So obviously a man came up with the term of painless tightening. Sometimes, yes, like sometimes you can tell, and it really does sometimes just feel like your stomach's just kind of balling up. But sometimes it can feel very real. So especially as you're getting closer. Braxton Hicks are your body's way of rehearsing. You know, they're getting ready to do a big show, so they're having rehearsals to practice. And sometimes you can't tell. What's that? Yeah. So other things that you'll see if they start having vaginal discharge, especially if they weren't having bleeding before, they'll have bloody show. So bloody show is where you'll start having bloody discharge. There's something called a mucus plug, and most women don't even know that they lose it. It's literally what it sounds like. It's a plug of mucus that plugs your cervix so infection can't get up in your uterus. And then as that cervix starts to dilate, it falls out. It might fall out in the toilet or things like that, and you never even know you lose it. But yeah. Yeah, they're irregular. Yep.
Was at this state. It wasn't like 3 minutes, 5 minutes, 7 minutes, you know.
But like if you're like a first time mom, how would the first time mom like go give real
Count them. Yeah.
Practically might say like they might stay for like an hour, right? Like a regular and then
Right. Right. Yeah. Right. And that's all right. There's nothing wrong with that. You know, I was such in denial with my child. I knew better. So she was preterm. You know, most when you go into labor, it's not like Hollywood where, oh, look, there's a puddle on the floor. Usually contractions start first and then your water breaks. She decided to be all kinds of mess. Not only was she preterm, but she decided to rupture membranes first. I was getting out of, it was my baby shower, the day of, afterwards, and I was going to spend my gift cards. Getting out of the car, getting home from Toys R Us, and that tells you how long ago that was. And then whoosh. And I was such in denial. I'm like, oh, I must be peeing on myself. I even went and sat on the toilet, and I'm like, there's no way. I'm even calling labor and delivery, and I'm like, it just won't stop. And they're like, honey, you need to come in. You're in labor. Come on. But I was such in denial that was actually what was happening, even though I knew better. But, you know. But that could be something. You could have rupture of membranes. Weight loss, a lot of women have, and it's not extreme weight loss. It's usually maybe 2 or 3 pounds, maybe 5 pounds, a couple days beforehand as they start having those fluid volume shifts. They get something called nesting, and it's where they get this big burst of energy, and they want to put together the crib and wash all the clothes and clean everything. Exactly. 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 What's that? 15th.
No, 5th.
Oh, 5th P. I'm sorry. I thought you said 15. So the 5th P is position. And we won't go into different, actually, we will in a minute. Position is how the mom is positioned. So most of the time when women give birth, how do they give birth? Flat on their back with their legs in the air, right? Lithotomy position. That is the worst position to give birth to a baby. I don't know. I think it's convenient for the doctors, but it is not the best.
I think that's why I want to do a water birth. Because I think with the water birth, they have you like on your knees.
Yep, absolutely.
It's more natural, like just going down.
And that's the best, actually the best position. A lot of hospitals now have what you call squatting bars. So it's a bar that fits into the frame of the bed, and you actually hold on to it and you squat, and that helps baby come down. But on your hands and knees is another good position. It opens up the pelvis and. Yep. Yep. Because back labor is caused by the baby's head pressing on your coccyx. Now, that would be one reason not to get an epidural, is because that would obviously not be best if you have an epidural to use a squatting bar, because, I mean, people have done it, but yeah. That's right. All right, so this is another one. Do not care about this. This just shows you how baby comes out. So when baby comes out, they don't come straight out. They actually have to twist around the pubic bone and bend and extend and flex and all this mess to get out into the world. And that's where sometimes you can have issues with, is if they don't bend and flex the way they're supposed to, then they get stuck. Or if they're a macrosomic baby, like we talked about last week, that can make them get stuck too. But this one, moving on. So when they are admitted to the labor and delivery unit, so this picture should look familiar. It's the same one we talked about last week with external fetal monitoring. So there's 3 things we need to assess as soon as they come into the labor and delivery suite. We need to know, how is mom doing? We need to know, how is baby doing? And we need to know, how close are we to the big show? So we'll get mom's vitals, we'll get baby's fetal heart rate, and we'll check a cervix to see how dilated she is. So those are the 3 big things you need to know. Obviously, there are other assessments they'll do. They'll get a urine, but those are not priorities in the initial. Because if baby's right here and they're about to come out, we don't really care what your urine looks like right now. All of them are, well, they're all important. So all of them have equal priority. So the mama's vital signs, fetal heart rates, and checking how close they are to giving birth. So checking the cervix and seeing how dilated they are, or where baby's head is. It might not matter how dilated they are. Baby's head's right there.
This is so awesome. So is it like the body communicating with the baby?
Kinda. Right? Kinda. Ideally. I know. I find reproduction and birth the most amazing thing our body does. Exactly. Exactly. It's crazy.
And when you see the baby, like you are seeing a brand new human.
Exactly. Exactly. So we talked a little bit about true and false labor already, comparing the two. And this is on, there's a table on page 137 in your book that compares the two. That's a good reference. So when we're talking about true and false, again, the biggest difference as far as a physiological standpoint is true labor is going to cause dilation and effacement. Braxton Hicks are not going to cause any cervical changes. But the other things we talked about as far as regular versus irregular, activity affecting or not affecting, and things like that. All right, so fetal heart rate. We already went through how to assess fetal heart rate, so I won't go through that in too much detail again. Veal chop. If you don't know it by next Wednesday. I guarantee you it will benefit you immensely if you know veal chop mine. Yes, ma'am.
Fill in the blanks on your exams. I'm just trying.
Absolutely. Every question is essay. No, really not. The only fill in the blanks I have are the math. You're like, I'm just dropping it. Forget it. No, the only fill in the blanks I have are math. Absolutely. I can already see the sweat starting. Oh, no, they're all either multiple choice or select all of the plot. I wish I could. I'm not a fan either, but you know that we have to make sure y'all are ready for NCLEX with those. I agree. We did start in last semester. Oh, you mean semester to semester? Yeah. So this semester you'll have 20% select all that apply. Yes. Yep, 20. So we progressively we do an 80 and 2. We progressively increase it. Yep, and we also increase like the application and analysis too. Like y'all do 80% application and analysis instead of whatever it was. I think it was 50% for y'all second term. because y'all are going to be ready in 3 months, maybe 4 months. You'll be amazed how much doing those weekly proctored tests in your capstone, by the time you get to the end, you're like, oh my gosh, I've learned so much doing capstone. Because at the beginning they're like, oh my God, I'm never going to make it. I'm going to fail capstone. I don't know what I'm doing. And then by the time they get to the end, it's, yes. Did I just say what y'all said earlier? Yeah. I hear it every semester.
Yeah, and suppose you did on Facebook about the calculation.
Oh yeah.
Yes.
Yeah,
5 plus 10 equals 15. And there's nothing wrong with that. Nothing wrong with that. But I promise you, by the time you get to the end of capstone, you'll be like, oh my gosh, I can see where I have come from at the beginning. Absolutely. And it really will help you. And I recommend y'all get green lighted, which I know by then you're going to be like, I don't want to see another question in my life. But it will help you. It's a lot of work, but it will help you. And it'll be worth it. Promise. Yeah, I think ATI has some really good questions that are equivalent in complexity to the NCLEX. Some of them cross correlate. Yep.
Now for the questions on ATI, they have like a hard level. Are they going to be tested like that on the NCLEX?
Some of them will.
The hard level?
So the way NCLEX works, NCLEX is a smart test. So you start with your first question. It could be some random question. Everybody starts out different. And based on how you answer, whether it's correct or incorrect, it's going to figure out what your next question is. So either the intensity is going to get harder or it won't, based on whether you're getting them correct or not. The topics of the questions are going to be based on what you're doing. So if you keep getting, say, OB questions wrong, guess what it's going to keep giving you? OB questions. So it's a smart test. It's not where it's just random. It really does calculate the next question based on what you just answered. But y'all can do it. Because y'all are going to know everything by the time you get done with capstone. Everything. All right, so monitoring the fetus. Again, fetal heart rate tracings is where this is really our only way to evaluate how baby's doing for the most part, is monitoring that fetal heart rate. It can give us a lot of information. So again, if you don't know veal chop, know it by next week because it will help you. So on page 139, it talks about monitoring low risk versus high risk. You don't have to worry about that. It's just more that if they're high risk, you're going to monitor more often. Low risk, if they're low risk, a lot of times they'll just pop that monitor on, check for a couple minutes, take them off and let them get up, walk around, do whatever they want. Unless, of course, they have an epidural, something like that. They can't get them walk. But higher risk, they might have to stay on it all the time. So as far as fetal heart rate, what's a normal fetal heart rate? 110 to 160. Beautiful. And in case you don't know, it's right there. So baseline heart rate, 110 to 160. So we don't really want to see that outside of those parameters. If it goes a little above and it comes back down, probably okay. But and then we are not only just looking at the number, but we're looking at what does that heart rate mean. And that's where those accelerations and decelerations come in. So make sure you know veal chop if you don't already. And I have several resources loaded under the week 3 content that just describe different charts, examples of strips. The grade that Kamala was talking about with game that she was talking about where you do the strips and you figure out what it's reading. Again, it is much, much harder than you need to know, but it kind of lets you play with it a little bit. But I encourage you to look at those things. Yes, ma'am.
So the baseline, moderate, marked, absent, variable.
Yes, let's talk about what variability means. So when we're talking about variability, it is basically how wavy the line is of the fetal heart rate. And the reason this can become important is if it's not very wavy, it could be a sign baby's not doing well. So when you look at fetal heart rate, you don't see a line like this, right? It doesn't say 150 the whole time. Baby's heart rate does this, where it bounces up and down. Might be between like 152 and 156 or something like that, right? That waviness is what we call variability. And the reason this is important is it can indicate drugs that mom may have used, for example. So when we're talking about normal variability, we call it moderate. So it kind of looks like that. You know, it's bouncing up and down. That's okay. Let's say mama decided to use some cocaine before she came in. What does cocaine do to your heart rate? Well, hopefully not your heart rate because you don't use cocaine, but an adult's heart rate. It makes it go high, right? So anything that makes your heart rate go up is going to cause increased variability, or what we call marked variability. So instead of looking like this, it may look like this, where it's bouncing up and down and up and down and up and down. Well, not necessarily tachycardia, but it's just bouncing so far. So when you think of tachycardia in you, for something that would cause tachycardia in you, that's what it looks like in baby. Versus, let's say mama just had some fentanyl. It might look like this, where it's barely moving. And that's where you have the decreased variability. So things that would make you sleepy cause decreased variability in baby. Well, absent would be not dead, but they aren't responding very much. So it could still be their heart rate's 150, but it's just not varying very much. Yep. So minimal. Yep. The normal one, I guess you'd say, is called moderate. Oh, my marker's running out. And then that's real bad. Absence. So things that would cause tachycardia in you will cause marked variability in baby. Things that would cause, say, bradycardia or make you sleepy will cause minimal. Yeah, this one right here is normal.
Well, then what's the moderate one that's up there? The same thing?
What do you mean?
Okay,
That's
you
up
have
there.
baseline, moderate, marked, and absent.
Oh, yeah. That should be over a little bit. Like from the baseline variability, those should basically be bullets under that. So when you're looking at baseline, you're figuring out what their average heart rate is. So when you're reading it, for example, it's kind of near 150. So you probably look at a heart rate of 150, for example. Baseline is the average in between.
So absent is dead.
No, absent is not dead. Absent is where their heart rate is not jumping up and down. It's just staying the same number.
I guess I'm a little confused on baseline and moderate. The moderate is that more.
Correct. Baseline is just what their base number is. So their baseline could be any number. It's what's in the middle. Baseline is what's in the middle.
So baseline and moderate are basically the same thing.
No. You could have a baseline heart rate on this one, and it's whatever falls in the middle of it. Does that make sense? Just like you could have, you're not going to see it as much, but you could have a baseline on this one, and it's whatever falls in the middle of that one. What's that? I'm sorry. It just tells you what their average heart rate is. So their baseline heart rate is their average heart rate. So if this were falling right in the middle, let's say it was 150, then your fetal heart rate, we would call it 150.
So does every variable have a baseline?
Yeah. Yep. You got it. So on page 141 in your book, there is a box that has good information as far as talking about reassuring versus non-reassuring patterns. And what we mean by that, reassuring is where they're doing well. So that they look like this, or where they're having those accelerations we talked about, baby's okay, great. Non-reassuring means something wrong. That could be your late decelerations, for example. 141. You're welcome. All right, I'm gonna let y'all take a break, and then we'll come back. Not that one, that one.
Which one you said was bradycardia in the mom?
Less in the mom?
The minimal.
Oh, the bradycardia is still going to be less than 110.
No, it's not on the list. Okay, so what will minimal be? And on compared to what's on the list on this PowerPoint?
This right here, where there's not a lot of variability.
You have baseline, moderate, marked, and action.
Correct.
So is minimal just in addition to that? Or does it fall into?
Oh, is it not on there? Oh, yeah, it's just not on there. Sorry. I ever thought it was on there. So you got a little bit of movement. All right. So let's talk about care of the woman during the stages of labor. So one of the things we're going to look at when her membranes rupture, whether it's natural and she breaks her water herself, or whether it's artificial, is we want to make sure we're looking at that amniotic fluid. Obviously, the most important thing when she ruptures her membranes is what? Baby's heart rate, right? But the next important thing is looking at that amniotic fluid. Typically, it should be clear. It might have little white flecks in it from the vernix that's on baby, but overall, it should be clear. And it shouldn't have an odor. So amniotic fluid that looks like that. Is that okay? Ew, no, it is not. Yes, that is your meconium amniotic fluid. It is bad. I think somebody had a dartboard and they said, let's see. Yeah, a lot of the words come from Latin base. So when we see that, we would know baby has some kind of distress. So we would be concerned about when baby's born, they could get an aspiration pneumonia of that meconium. So we'll talk about that more so when we get to newborns, but that would be concerning for fetal distress. As far as the amounts, you see amounts listed for amounts of amniotic fluid. You don't need to worry about that. Don't worry about memorizing those, but they do pay attention to how much it is. If it's very little coming out, why? Did they already not have enough fluid? Or is maybe the membrane's not completely ruptured? What's going on?
Is there like an average amount that they say, okay, this is not enough, we're discussing it?
Yeah, that moderate. Go about 500. But you don't need to know that. And then if it's cloudy, purulent, those kind of things, that could be some kind of uterine infection. And those would not be good as well. So when we're talking, I don't know why I did this slide.
That looks like that.
That looks like the real deal.
Yeah, that's what's really going on when you're in labor. So a big, I am very ashamed of the way I acted with my second one. Let's just say that. Yeah. 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 Now I wasn't cussing her, but my second one, my epidural did not kick in, and security actually came down the hall because they thought like somebody was killing me. But you know.
I can imagine it's very loud.
Yeah.
Oh, I need to because I want to hear the different situations.
Right. And you have some people that are some cultures are very stoic and they don't express pain, so they're completely silent. Mm-hmm. Right. Right.
I mean, I have a stepson.
I'm gonna say I really don't know y'all.
Yeah.
All right. So when we're talking about the first stage of labor, a lot of it is supportive. A lot of it is pain management, especially your non-pharmacological pain management. That picture in the bottom, what is that called? Do y'all know? You can see it. It is. It's called sacral counterpressure. So it's where you usually use the heel of your hand and you push into just above where their sacrum is. And it actually, usually back labor is caused by the baby's head pressing on your coccyx and your sacrum and causing pain. So if you take your hand and press against it, it kind of pushes that head up off their sacrum and can relieve some of that pressure. So we talked about positioning. I don't know why this is way down here. I need to move it up. So the top one with the bar is what I was talking about, where they'll have the birthing bars and they attach into the bed and you can squat and hold on. And what's that? Why? How happy they look, or?
So many things. Because first of all, this looks like second. Let me start. Hold the position. Now you get like this is like the guy right under her and try to make everyone lick what's that. But that's not my real question.
What's your real question?
It looks like how because I see the little sitting part thing,
Right.
And the thing under it. How do they get the baby? Like it looks
Stick your hands up underneath and maneuver.
Like it's gonna fall. I'm confused.
The thing that she's standing on it's detachable.
Yeah.
And the way that I did it, I actually had my feet, so I was like this.
Oh, you did that?
Yeah. Demonstrate.
I hold on to the bar like this.
You did that for all 3 hours?
It literally has like 25.
So then you have your hips open so that the baby can descend there.
Yeah.
And I'm holding on to this as well to stabilize myself as well. And then the midwife is right here, and she just catches it.
Yep.
Oh.
Just slide them right on out. Yep. Maybe you'll get to see it in Norfolk. You know. There you go. E6000 like the glue? Lord. So really, like I was talking about with lithotomy, which is you're on your back with your legs in the air, it's the worst position because you're working against gravity trying to push this baby out. Positions like this, like the bottom one, I mean, you're on your hands and knees, but it opens up your pelvic bone, so it actually helps. If you're having trouble with progression, sometimes they'll tell you to get in that position because it'll help open you up. Obviously, the one on the top is not advised if you have an epidural because of the potential that you could fall. It really can cause some numbness. Yeah.
It feels really, really good when you're like,
Yeah. Yeah, absolutely. Absolutely. You will. You absolutely will. Yep. You will. That's why they used to, back in what, the 50s or 60s, actually later than that, I think in the 80s they were still doing, they would give women enemas before labors. That way. Yeah. That's all right. They're used to it. They take those chucks and cover it up so fast. Mm-hmm. That's all right. Yep.
if you're doing it naturally, you don't care. Get it out.
Yeah. All right. So let's talk about stages and phases of labor. So there are technically 4 stages. The 4th stage, though, is really where we're talking about that first couple hours after a birth where there's the mama's stabilizing. So it's really kind of transcending into that postpartum period. So on page 70 in your ATI book, there's a nice little chart where it outlines the stages. So stage 1, think of this as that dilation and effacement part. That's your labor part. That's where you're getting from 0 to 10. That's the longest part and the most unpredictable in time. So where you're dilating, effacing. The end of stage 1 is when you're fully dilated and effacing. They say, all right, let's go. And they are ready to birth the baby. So once baby's head is there, engaged in the pelvis, ready to come down, that's when you're transcending from stage 1 into stage 2. So stage 2 is birth of the baby. So from the time you say, okay, we're ready, to the moment they say baby's time of birth is this, that's stage 2. So baby coming out is stage 2. Stage 3 is placenta coming out. So from the time baby exits to the time the placenta exits, that's stage 3. And then again, stage 4 is a small period of time, usually a couple of hours, where they're checking vital signs and stabilizing mom and baby and making sure they're okay.
So this is considered like, when people ask how long were you in labor, is this like the whole?
Yep.
All of that?
Although a lot of times people gauge labor by once baby comes out, but truly it's not over until the end of the 4th. But when people say I was in labor for 8 hours, usually they're counting from the time they felt the first contraction till the time baby's feet come out. So
What if you're gonna do count that at the beginning of labor?
yeah. Yeah. So once they once they start those medications, or depending on how they induce you. Mhm. Not necessarily. So contractions, a lot of times with labor, contractions start first. Yeah. Yes, they can. That's pretty, yeah, where the whole thing comes out and the water never breaks. We are just blowing your mind. All right, so on page 155 to 156, in comparison to these stages, it also talks about in your book the nursing interventions related to all these. So first stage, for example, it's really a lot of comfort care. You're helping them through their pain, monitoring for complications, things like that. Your second stage, you're assisting with a lot of times holding a leg, to be honest, and monitoring, making sure that there's nothing going awry. Third stage is going to be assisting with a lot of the newborn by that point. And then fourth stage is a lot of vital signs, checking, make sure she's doing okay. And then again, the fourth stage, so like I mentioned, oh shoot, I forgot to bring my placenta with me. I'll have to show it to y'all next time. So a placenta is about, not my placenta, the artificial placenta that belongs to Noelle. That's in my office. Sorry, I should have specified that one. Noelle's placenta, or simulation mannequin. Placentas are about the size of a dinner plate. They're actually pretty large when they come out. So I know that picture, it doesn't really give it justice. So, yeah. So when we're talking about fourth stage, we're assessing for complications. We're looking to see if there's like lacerations, if they're having excessive bleeding, giving them, most hospitals do what they call the golden hour now with newborns, where they put them immediately to mom's chest and leave them alone for an hour as long as baby and mom are stable, so that they can have that bonding time, start breastfeeding if she chooses to, things like that.
Do we not massage belly anymore?
Yeah. Oh yeah, fundal massage. Yeah, we'll talk. That's more of a postpartum where we talk about it. But yeah, they'll do that right away, where they make sure that uterus starts contracting.
In the fourth stage, that starts.
It'll a little bit, yeah, but they don't focus on it as much right then. So then immediately after birth, again, vital signs, making sure they're okay. Ice packs. Ice packs are fantastic to the perineum. They have pads with the ice pack built in. So you got an all-in-one pad that will collect vaginal discharge and cool your behind too. Kind of. So it's a little bit of a lot of sensations going on. A lot of times it's sore. Really the biggest thing with the ice packs is because you're very sore. It's a lot of bruising, so it helps diminish that bruising. Mm-hmm.
Overnight always.
Yep. Yeah. So I will tell you the rest of this chapter. If you're following along, you're like, wait a minute, we're not at the end of the chapter. The rest of the chapter talks about the newborn more specifically. So to keep it separate, I want you to stop right here where it talks about four stages as far as for our purposes for testing for next week. When we get to newborns in week 6, then we'll talk about the rest of the information that's in that chapter more specifically related to newborns. So we keep all newborn stuff together, but this is where we stop as far as what we're covering today for this chapter. What's that? Oh.
So this nursing after birth, does that kind of correlate with the fourth stage or no?
Yeah, absolutely. It is recommended to, if you're planning on breastfeeding, to breastfeed within 15 minutes after birth, because it helps establish, best establish that new milk flow, which they're not producing milk usually yet, but it helps establish adequate breastfeeding. Yep, it does.
So like even if it's not like, I guess it's
Producing.
Yeah.
That's okay. That will help start stimulating it, so it will.
But I mean, you're already producing the milk while you're pregnant, right? It's just
not necessarily. Sometimes people will have leakage from their breast, but usually when you first have a baby, you have something called colostrum. It's like this yellow gold color. You might start producing that ahead of time, but sometimes women don't produce it until after they've had the baby. So it'll get that process moving. But yep, even if they're not, because babies really aren't hungry for the first couple days of their life. They don't really need that kind of nourishment, but it gets that process starting. Which they do. It's that HP, remember all the hormones we talked about last week, that HPL. I said don't really worry about that one. That has a factor with that, yep, where it'll start during pregnancy. All right, so I will tell you this nursing management of pain is probably the shortest chapter of the entire semester. It's not even that long. So let's talk about pain management. And most of the things y'all need to know about pain management for this, you probably already know. Things as far as non-pharmacological versus pharmacological. Women will use a variety of both. Sometimes they'll only use non-pharm. Are you laughing at my cartoon? That's funny. But a combination non-pharm, pharmacological, sometimes one or the other. So it just depends. It's very individualized. And even their threshold and their expression, we already talked about that. Some women are there are some cultures that don't believe in expressing your pain. So they'll sit there and seem like they're fine, but they're in a lot of pain and they just don't express it. Right. So we can't say that you're not in pain because you're just sitting there.
Oh, wait, can I tell you guys something funny real quick?
Yeah.
You guys know I homeschool, and so I was teaching my kids about contractions, and so I was testing their memory to see, like contractions, like the word can't. Like,
oh, I'm thinking contractions.
And so I said, so what is a contraction? And I swear it was so funny. My 12-year-old, who's a boy, speaks up. He goes, that's what women have when they're in labor.
I mean, he's not wrong.
He's been around, he didn't realize that's what that was. He didn't put two together. And so, anyway.
He's not wrong.
And like I say, they use the labor and I kind of
Right. All right, so non-pharm means we're not using any medications. So there are tons of different things you can use, everything from massage and effleurage, which is where you rub the abdomen, that sacral pressure. Again, here's another example. Using distraction, using even hypnosis. You'll see a lot of labor and delivery suites even have diffusers in them. They're using essential oils more and more for relaxation. So there's tons of, although that kind of starts going into the pharmacological, but the non-pharmacological methods are talked about on page 167 in your textbook. So really it's whatever helps them transition through that pain, but without the use of medications. Lamaze, absolutely. And part of Lamaze that you see is breathing. Now, your book goes into so much detail. If they're having this contraction pattern, use this type of breathing. You do not need to know all that. But breathing can help with pain, especially their pain threshold, kind of bring it up a little bit so they can tolerate it a little bit better. The biggest thing is those signs and symptoms of hyperventilation, as you see. Breathing is good because if they're using pace types of breathing or controlled breathing, it will hopefully prevent them from hyperventilating. But you do not need to know the different types of breathing. And then the other side is drugs, medications, pharmacological pain management. So when people think of pharmacological pain management, they think of an epidural, which that's absolutely one way, but it's not the only way. You can get IV medication, like some IV fentanyl or morphine. They can do something called a spinal block, which is similar to an epidural in the sense of they put a needle into the spinal column to put the medication. But a spinal block, they insert one time and give a dose and then take it out. An epidural is where almost like an IV where they put it in and they leave the tube in so they can continue to give medication until you don't need it anymore. So it's kind of a similar process, but just the way it's used. So there's different medications discussed on 172. These medications are probably going to be things you've heard of before. Morphine, fentanyl are a couple of big common ones that we use. So The benefits of pharmacological pain management is it's effective. Typically for most people, they find it very effective. The problem with pharmacological pain management, one, you can have complications, you can have allergies, all those things that you normally have with meds, but it also can dull the sensation of birth. It can make labor last longer, and it can just cause things to not progress the way that they're supposed to. So there are definitely negative factors that go with that as well. Again, there's different ways. We can do IV, we can do epidurals. Nitrous oxide actually came back in the medical world through the L&D department. You know, nitrous is what they use at the dentist's office all the time. It kind of went away from the medical profession. And then about, I don't know, 10 or 15 years ago, it started coming back again, and L&D is where you saw it coming back. They're not doing nitrous right now just because of, you know, COVID. But it's from what I understand, they're not. Because it's aerosolized, but it's great because nitrous oxide is something that you can just use when you need it. So it sits there at the side of the bed. You have a contraction, you put it on your face, you breathe it in, it works. And then when your contraction's done, you can take it off and go about your merry way until you need it again. Yes, ma'am.
So I saw on Grey's Anatomy, man, it may be true, but it may not be.
It could be up in the air on that one.
So they say that masturbating during labor is supposed to help labor progress as well as with pain. Is that a true thing?
Yep, because it causes contractions.
I've never ever heard that before. I'm like, I'm gonna ask them about this.
Yeah, it causes contractions. Yeah. Yep, that's exactly what it is. Yep, there's prostaglandins in semen, and they can actually stimulate the labor process. Yep, orgasms can stimulate it because of that contraction. Right. That's one of the reasons they also tell you not to have sex if you're at risk of preterm labor too. Because you could actually cause. Yep.
I have a question about that.
Yeah.
So, like, when you're giving narcotics and to the mom or whatever, does that, like, does the baby come out like a little high? I guess.
Potentially, yeah, absolutely. So it's good to have Narcan at the bedside, even if mom is doing okay, because you don't know how baby's going to come out acting. It could be where they got, because it does cross the placenta, so baby's definitely going to get it. But if mama got it 8 hours ago, it could be out of baby's system by then, but maybe not. So if they come out, you know, with not breathing very much, you might need to give them some Narcan. Absolutely. No, that does not get to baby, and that well, because most of what they focus on in an epidural is an anesthetic. So analgesics are your pain relievers, like your fentanyl and your morphine. Anesthetics are numbing agents. So these are designed for numbing as opposed to like pain. If they do it incorrectly, I don't know. Yeah, I don't know.
My mom had it all natural, so
yeah. More power to her. I gotta say it. No, it's all right if I never walk again. Oh, was there a video in the module? Yeah, I know, right? So I will tell you, I'm not totally clueless. I know what y'all do. Y'all go in and you take the test and you submit it. But I would recommend seriously before your test next week, go back and look at some of the module stuff. Like, or I know one thing that I really like, they have a good breastfeeding video, which we're not doing that yet. We're doing it newborn. But like when we go to test 2, even go back and look at some of those videos and those modules. They can really help you bring it together. I know what y'all actually did for homework. It's okay. But I would say go back and review some of it. Hey, wait. So if you haven't seen what an epidural looks like being inserted, This is kind of what it looks like. It's a very large needle. And the needle does not stay in. It's kind of like when you do an IV, you use the needle for insertion, and then the needle comes out and it's a plastic sheath that's actually left in the spinal column. So they are really great because you can leave them in. What's that? Yeah. Yep. So these are great because you can continue to use them, you know, for a period of time. It's not like a spinal block where you get the medication once, and then if you start getting in pain again and the anesthetic wears off, you're kind of screwed. The biggest complication of having the epidural inserted is hypotension. So it's very, very common for women to drop their blood pressure when they're inserting that because of the change in pressure in the spinal column. Usually they try to prevent this by giving the mom a liter bolus first through her IV to get her well hydrated, so that way you don't have to worry about her dropping her blood pressure. That's part of it, yeah. And that also standing in front of them. So the way you do an epidural, they are sitting up like that, and you have the nurse standing in front of them, and they lay their head on the nurse's shoulder, so that way it curves their back too, so you can.
So they won't actually see my face.
Right.
I have a nurse the same size as the person, because I had like this little lady. She's like,
oh. That's funny. Oh my gosh.
Like I'm looking for somebody like Regine.
So one other option, which typically is not used as a regular thing, is general anesthesia. General anesthesia has a lot of risks. This is when same thing we do when people go to the OR. And it's usually not necessary. Even for C-sections, you can just do an epidural and it will numb you enough that you don't need this. General anesthesia is usually just reserved for like emergencies. So to put an epidural in takes a few minutes. And then for an epidural to work, it takes like 30 to 45 minutes because it has to actually go down your nerves to your feet and work back up. And that's how they test that you're numb. They'll tell you, they'll feel kind of up your leg and say, where's the point where you feel the difference in the sensation? And they can tell how that medication is working up your body. So if you have an emergency, baby's heart rate drops to 50. Oh shit, we got to get baby out of there. You think they got time to do an epidural? They do not. So that's where anesthesia can come in, because you can do anesthesia super quick and knock them out in less than a minute. Yeah. And sometimes people will do it electively too. But yeah, if they need baby out quick, they can do general. But it's not done routinely. Any questions on what we talked about so far?
Can you have surgery at the same time as like a BBL possibly after giving birth?
Yeah, absolutely.
And that doesn't affect anything with healing or anything?
It depends on what you're having done. Like sometimes, especially if you're getting a C-section, they'll go ahead and do a tubal ligation while they're in there, just to, you know, sum it all up. But so we talked about the normal stuff. Let's talk about the abnormal stuff, the complications that would happen. So this is a little bit of a longer section. So when we're talking about induction or augmentation, the process is the same. It's just what they mean. So induction is where you're not in labor, you're hunky-dory, and we're going to put you in labor. Augmentation is where you're already in labor and either labor stopped or labor is not doing well, and we need to give it a little boost. So the ways we do it is the same, just a little bit different terminology. So there's various different reasons that people get induced. It could be elective. It could just be, get this baby out of me. But it usually is because of some kind of medical problem. Like we talked about preeclampsia last week and gestational diabetes. If they're having a lot of complications from that, especially with the preeclampsia, they may weigh the benefits versus the risks and see it's better to get baby out than leave baby in, even if they're going to be premature. So that could be one reason. If the membranes rupture, it doesn't matter where you are. If you are 22 weeks gestation, you're very far away from the end, but there's no way to tape the membranes back together. It doesn't happen. So you have to go into labor for that. Why is my thingy clicking? So contraindications to labor induction. So any reason that we've talked about several reasons over the past couple weeks that you would not be allowed to have a vaginal birth. So any reason you wouldn't be allowed to have a vaginal birth would be a contraindication. Like for instance, active herpes infection, a placenta previa, those kind of things. HIV. So usually in women that have these conditions where they would not be able to have a vaginal birth, these are also women that will often be scheduled for C-sections ahead of their due date, even if it's only a week or so. That way they can prevent them from going into labor naturally. Because we don't want them to go into labor. So how do we stimulate contractions? So there are some medications we can do. You can do nipple stimulation, like we talked about the nipple stimulation contraction stress test last week, where we can stimulate contractions because nipple stimulation releases oxytocin. It's our body's natural way of stimulating those contractions. It helps during labor, but it also, we'll talk about this again in postpartum, how that oxytocin helps contract that uterus and keep us from bleeding. So we can use things that do what we call cervical ripening. It basically softens the cervix so that it will open up easier. Things like misoprostol, which you may have heard it called Cytotec.
What's the name of that balloon that goes with the Psyche?
I know exactly. So basically what you do is you take this balloon, you put it in the cervix, and you open it up kind of like you would a Foley balloon, and it pushes the cervix open. Why can't I think of what it's called?
And then what?
And then hopefully it's telling that cervix, get it together, and the cervix will start to open by itself. They'll also do something called stripping your membranes. If you've ever heard that term, stripping your membranes, it's literally what it sounds like. Usually they'll take their hand, a provider will, and they'll actually run their hand in between the amniotic sac and your uterus, and it kind of pulls it away from the edge and stimulates all those hormones to get started. A lot of women say they'll go into labor within 24 hours after that. So we have to be careful though with labor inductions because when we give these medications, we can get something called uterine hyperstimulation, which is where you're having contractions too frequently. So if they're having contractions basically more than 5 in a 10-minute period, so more than every 2 minutes, that's too frequent. And the reason this is a concern is when the uterus is contracting, it's all clamped down, baby's not getting oxygen. So baby oxygenates in between contractions when the uterus is relaxed. If the uterus is never relaxing because it's contracting and there's no rest in between, baby's not having time to get oxygen. So you'll start seeing where their heart rate will start dropping a little bit. So I mentioned an amniotomy. I don't know if you can see that middle picture. That's what an amni hook looks like. So it looks kind of like a crochet needle with a little beak on the end. And it's a little hook, and they'll reach up and grab the bag and pop it open if it doesn't do it on its own. So sometimes the amniotomy in and of itself will stimulate contractions because the body realizes, oh, wait, the water's not intact anymore. So monitoring baby's heart rate, monitoring the characteristics of the fluid, those are the most important things when we are doing an amniotomy, but especially that fetal heart rate, because if, again, when the membranes rupture, all that fluid rushes out, it can pull that umbilical cord down next to baby's head. Yeah, yep. That's when it's done manually, yeah. If it's done spontaneously, where the mom breaks her own water, it's called rupture of membranes. So you can have artificial rupture of membranes, which is this, where they actually cause it to happen, or you can have spontaneous rupture of membranes where the mama does it on her own. And then we already talked about some of the non-pharm methods. Did you have a question? I'm sorry. Oh, no, you're fine. Yes. So you can do nipple, yeah, where it's more squatting like. So you can do nipple stimulation, walking. Walking will make contractions more prominent if it's true labor.
So it wouldn't be weird if you're like about to give birth.
What's that?
It wouldn't be weird for like nurses as a patient to be like.
Nope. Yeah, usually it's going to be the mom or the mom's partner, but I mean, if you're feeling, you know, very helpful that day, I'm sure they wouldn't mind. Yeah, breast pumps will work too. Yeah, I was so desperate with my second one to come out that I started using my breast pump like a week ahead of time just to see if it would cause some stimulation to rupture my membranes or something. It didn't work, by the way. Exactly. He's still stubborn. So then what we look at is episiotomies and lacerations. And unfortunately, this is the most mild picture you're going to see because when we get to postpartum, I got a whole lot more for you. So, yes, so this is exactly what you want an ice pack for. So,
Yeah, I found that. All that.
let me see. Oh, no. Yes. So, shoot. No, I didn't. All right, so let's talk about the difference. I'm going to use one of y'all's scratch pieces of paper from your test to demonstrate. So you don't see episiotomies used quite as much as you used to. The thought process between doing an episiotomy is that it opens up that pelvic canal, so you have more room to baby to come out. And the other thought process is it's easier to suture a cut line than it is a jagged line where the skin has torn. Makes sense, right? Except here's what happens when you do an episiotomy. Yeah. So here's what happens with an episiotomy. So this is your perineum, right? This is your vagina right here. And you got all this tugging. And you got intact skin and it doesn't tear, right? Because it's intact. Let's cut it a little. So you've cut that skin. Guess what cut skin does? That's exactly what happens with episiotomies. They actually make tears worse. Because you have impaired the skin integrity. They do. Yep. So that's what I'm going to talk about. So the ideal way, the better way to prevent tears is actually what they call perennial massage. So and they usually use an oil with it, even just plain old mineral oil or vegetable oil, even if you're in a pinch, where you actually take your fingers and massage the lower part of the perineum down near the rectum, and it will stretch it so that it doesn't tear as much. And you don't have to do it for long. You can do it for a few hours. Yeah, absolutely.
No, he did not. Matt, and how many centimeters he goes?
I'm sorry?
Like in this cut, how many centimeters?
How many centimeters?
Usually a couple.
Yeah.
It's a pretty good size. Yeah.
Can I say something about natural
Yeah.
childbirth? Okay, so with natural childbirth or like with midwives and stuff, they will suggest that you start that before.
Absolutely.
So you actually stretch out stuff so you don't.
Yeah.
I'm just saying.
Yeah, perennial massage. Yep.
Awesome. Oh,
Yeah.
my gosh, I will never.
Have you ever been to midwife?
I'm not looking for that. Okay, I did the midwife. I had a whole team when I did.
Yeah.
I had a midwife, I have a doula, I have a high-risk doctor, and I have a regular OB.
Yeah.
High-risk doctor?
Yeah, I can't have like regular kids. I go into labor too quickly.
Yeah.
Easily. I have to like my cervix. You know how she was showing this slide how like it was long. I had cancer and it never like happened.
Oh, okay.
And so I have to be self-closed.
Right.
And so I have to be on bed rest, I have to be monitored, but I have to make it to the point where they can actually put that in there.
Right.
It's like it's really
It's a big ordeal. Yeah.
Oh, okay, yeah. And then
Yeah.
I do as much natural stuff as I can. That's why I have the midwife.
Right.
I have a high-risk doctor, and then I have a regular one that monitors in between just to make sure. And I have to
Yep.
shop. I mean, it's good.
Yeah.
You do that 10 times?
I have 8 living children and total 17 pregnant.
Yeah.
Oh, wow.
All right. So we talked about episiotomies, laceration. So a laceration is a tear. And lacerations are very common. Sometimes they can be very minor. Sometimes they can be minor enough that they don't even have to be sutured. But they can be severe. And I don't want you to memorize the difference in first, second, third, and fourth degree tears, but yeah, oh really? So you can go anywhere from, again, just having the slightest tear that doesn't even need to be, my doctor referred to it as a skid mark. They didn't even suture it. It was just barely like a superficial, or all the way up to fourth degree. Fourth degree is where it actually tears the wall that separates the vagina and the rectum, which of course could give you permanent complications. So it can get bad. Uh-huh.
So she wasn't able to have technically a vaginal birth,
Right.
but it was weird because I guess this COVID was going on. They still considered it a elective C-section.
Oh.
I would think that would be.
Yeah, I wouldn't think that would be either, but interesting. Oh, sorry. Yeah. Or perineal stretching. You'll hear it called both. Yeah.
With genital mutation, does that affect them at all?
Like female circumcision?
Yeah.
I don't think it would. I don't think based on the location where the circumcision happens that it would. I know a lot of women that have it done, they end up having like permanent pain problems. So that could affect it in that way. But I think anatomically it wouldn't affect them. We won't even go into female circumcision. So female circumcision is seen in, like she said, Africa, and I'm trying to think, like Middle East. There's some, not all of them, but there's a couple of Middle Eastern countries, I think. So it's where they cut out the clitoris. So the idea is for women, you see it in more patriarchal countries, and it's almost like used as a control feature, so the women can't have pleasure with sex. They cut out. It's female mutilation is what they'll often call it. And these women have permanent nerve problems. Sometimes yeah. Sometimes be glad you live in the U.S. Right. Right. At least they don't have permanent problems like that from it. Exactly. So a couple of assistive devices we use. One's called a forceps extraction. It looks like a giant pair of tongs like you use on the grill. Basically, they grab baby's head and help pull them out if they're not progressing very far. They'll do it with the vacuum extraction as well. So it's kind of the same process. You're helping baby come down, but instead of big old tongs, you're using a suction cup. Yeah. Which all babies have a cone head that are vaginal birth. It flattens. No, not like that. Not like that.
Aren't they kind of at risk of like dislocation type of thing?
Depending if they are, if they have what's called shoulder dystocia, which we'll talk about that in a second, they're more likely to get clavicle fractures as they're pulling on it. Yes, ma'am.
I was just going to ask it, do they have permanent damage?
Potentially. Potentially. They don't use them as much as they used to. Like if they're not used correctly, you can cause trauma to the head. Usually at most common, it'll just be kind of bruising on the sides of the head, but
like their bones are soft, so
right. Right. You could.
Some of these are like abortion methods too, like the vacuum and stuff.
Mm-hmm. Similar. So cesarean birth, let's talk about what a cesarean birth is. So a cesarean birth is where you cut across the abdomen to remove baby through the abdomen. And there can be, again, various different reasons for it. It could be just I don't want to have a vaginal birth. But usually there's some kind of medical problem. So reasons they can't have a vaginal birth, if there is something showing that mom or baby is compromised, they'll do a C-section. And there's two different incisions that they'll do. So we talked about this a little bit last week. Yeah, exactly. So most women, when they have a C-section, they have what we call a transverse incision, or you'll hear it called a bikini incision too. It's kind of low, right along the top of the pubic hair line, and it's horizontal. And that is the best one because if you ever get pregnant again, it's not going to pull on the muscles the way the other type will. So if you have a horizontal transverse incision, you can have a vaginal birth after that. But if you have a vertical incision, so they used to do more vertical incisions, they may still do it now if it's an emergency, like very immediate emergency, because it's quicker to cut that way. But the problem is it's also more likely to rupture if they try to have a vaginal birth. So vertical is not ideal. If you've never seen a cesarean, I want to show you a really cool little device that they have now. I used to have this amazing C-section video, and every time I find one, they take it down off of YouTube and say it's inappropriate. So I keep losing my good videos, but this one's pretty good too because it shows you a different device that I have never seen before until I saw this and I started looking at it. So when you have a C-section, they use what's called skin spreaders. So if you've ever seen any kind of abdominal surgery, they look like these metal, almost like these metal plates that are curved over, and they can use it to kind of pull open the skin. Oh, seriously. I promise I'm an adult. I love how you can verify your account on your phone now, and they just send you a number. All right, so this is pretty cool to use instead of spreaders. And I will tell you, there's not any sound to the video, so there's nothing to hear. But this shows you, and it's very meticulous. It's not where they just rip them open. They have to cut through every single layer. And the other video I had really showed you cutting through the layers. But this device is really neat because it holds the layers open while you're trying to get baby out without causing as much tissue trauma as the metal spreaders. And if you've ever seen abdominal surgery, you know what those spreaders, they're these big blade things that you pry it open. So this, they basically stuff the plastic in around it, and then they can use that to tighten it and open the incision up. It's less trauma on the tissue. And then they have this nice working area there where they can see what they're doing. Yep. So that's and there you're going to see the rupture. There we go. The water broke. I believe so, because I've never seen it. Woo! There's baby. I know, right? You see how they just yank on baby? That's a big baby. But he's breathing. And you see that gives them an area too, where now when they're suturing, they're not having to hold those spreaders open. And then when they're done, they just pull the plastic out and then they can suture up the skin on top. That thing is awesome. That's got to be a newer thing. I've never seen that before. And they suture up each layer. Yep, they sure do. They have to suture each layer. So the ones you're seeing them do right now are internal sutures that will dissolve. And then on the outside, I don't see sutures being used as much. Usually it's staples or glue. Yeah, I don't see many where they use sutures on the outside. But that device is pretty cool. I know, right? There you go. There you go. All right, so let's talk about dysfunctional or abnormal labor. So when we talked about those P's, the passenger and passageway and all that stuff, any abnormality in one of those factors can affect us having a dysfunctional labor. So this can be, there are different risk factors that can cause this. It could be if mom's diabetic and she has a macrosomic baby, that can cause it. If mom's obese, that can cause it. If she has other pre-existing conditions, that can change the intensity of her contractions. One of the big things you see with the powers is either hypertonic uterine contractions or hypotonic uterine contractions. So they are dysfunctional. Both of them are dysfunctional. The difference in them is hypertonic are really strong and really frequent, but they're not really being very effective. It's kind of like a comparison of if you've ever been constipated and you're having intestinal cramps because your body is trying to push the poop out and it's just not working. It's kind of the same thing. Your placenta, your uterus is working really hard trying to push that baby out, but it's not being very effective. So then hypotonic is where they're very weak. So they're low tone, very weak contractions. Again, they're not effective. Neither one is effective. But hypertonic, really strong and painful. Hypotonic is very weak. And there is a chart comparing those two on page 195 in your textbook. So I know we talked about macrosomia last week a little bit when we were talking about diabetes. So this is your full-term baby and this is your full-term toddler that was born at the same time. They are both the same gestation, but the one to your right is called a macrosomia baby. Generally, macrosomia is defined as when they hit 4,500 grams, so 4.5 kilos, so about 9.5 pounds. A big baby. So these are babies that are more likely to have trauma during birth, whether it be vaginal trauma for mom or they can get the shoulder dystocia. I'm going to show you a picture of in a second where their shoulder gets stuck on that pubic bone and they can't come out. So big babies can also cause problems. So you can have labors that are too slow, but you can have labors that are too fast. And that's what a precipitate birth is. So the definition of a precipitate birth is an entire labor and birth that lasts less than 3 hours, which is very short. That's how my second one was. As soon as they induced me, he was like, I'm ready. And I was done in 51 minutes from start to finish. I do not recommend, by the way. But it is a very fast birth, and it seems like a great idea, except these can cause more perineal trauma. It can cause retained placenta, where the parts of the placenta are left inside, and then they got to go get them. Or it can cause more risk of infection, so it can cause a lot of problems as well. So it's not a good thing. And then we have premature rupture of membrane. So this is not premature baby. So typically, when we're talking about the progression of labor and birth, contractions start first, and then your membranes rupture. This is where the membranes rupture before contractions start. And the reason that this is important is because if you go more than 24 hours before you give birth, it greatly increases your risk of infection. So it's not that at 24 hours they're going to force you to have a C-section, but they're going to start being concerned with the potential of mama getting a uterine infection or baby getting septic. So after 24 hours, they'll usually start antibiotics or something just to be sure. But if you have your membranes that rupture first and contractions don't start, that's what they worry about, that it's going to take too long. And then we've talked about preterm labor already. We talked about that with pregnancy. So anything that is from 20 weeks till 37 weeks and 6 days, so right before 38 weeks, is considered preterm. So preterm is not ideal. Of course, we don't want babies to have complications. If we're worried about preterm labor, that baby is not going to tolerate it, what can we give mama so baby doesn't have respiratory complications? Betamethasone, very good. So we will test babies, and this is the other way we use amniocentesis. So I mentioned amniocentesis last week, talking about that we use it for genetic defects, testing for genetic defects. But when we're doing it here, we can also do an amniocentesis to test fetal lung maturity. And if we look at that and it's abnormal, then we can give mom betamethasone and hopefully baby will, their lungs will mature enough to decrease their risk of respiratory compromise when they're born. So as far as concerns with preterm labor, they can get infections. They might not be able to stop labor. You want to avoid anything that can stimulate. So we talked about the nipple stimulation and avoiding sexual intercourse and all that stuff. That's all part of that can make the situation worse and cause labor to continue to progress. So tocolytics, these are those medications I mentioned. So it's not my time. So your indomethacin, your nifedipine, your mag sulfate, terbutaline. So these are medications that we can give to attempt. I would say magnesium is the drug you really need to focus on because it is the most common one that we give. And remember, mag mellows, so it's going to calm that uterus down. All right, last one, talking about some big emergencies that we can have during childbirth. So that picture you see up there is called a prolapsed umbilical cord. And that is where the umbilical cord is down next to baby's head. So it's getting compressed and it's not allowing, well, not with this, not with this. So a prolapse cord is where it comes down next to the baby's head and it is compressing that cord. This is where I was talking about whenever you have rupture of membranes, you check the fetal heart rate, and that's why, because you could have this. And it could be different situations. Like the one you see here is called a complete, because if you actually looked at mom's vagina, you would see it coming out. But it doesn't have to be. It could be where it's occult, meaning it's hidden. So it could just be where the cord is right here next to baby's head. So you can't see that cord, but you're seeing baby's heart rate drop, and it's because it's compressed right next to that baby's head. Exactly. And it is an emergency because baby is not getting oxygen. So there's two things you'll do kind of right away. One, you may put mama in the Trendelenburg position where you put her head down because the gravity will help. But the big one, like y'all are showing me, take your hand and push up against the head and jump on that gurney, and they'll take you to the OR right with mama. Really.
You got your hand up, keeping the
Yep, you're pushing up on the head. So you put your fingers around the head, making sure you don't compress the cord, and you push up on baby's head so it takes some of the pressure off the cord. Yep. Yep. Yep, so you put your hand up there and you get comfortable because you're not moving until baby comes out through the C-section. You're like, I don't know what are. Oh, yeah. Yes, please put gloves on. So ideally, you should have sterile gloves on. So it should be, and usually in L&D, they're really good about having supplies that you may need, not where you're going to have to run down the hall to find sterile gloves. So ideally, you should, and like you say, the long ones. But because you're in an area that's, open now, sterile gloves are ideally what you should be using. Just hold baby's head up.
But when you think the baby being compressed elsewhere, like you're holding it?
Do what? I'm sorry.
Like wouldn't the baby's head be kind of pressed up against the
No, because you lift straight up. So you're not going to like push it to the side. You're going to push up so that it kind of relieves some of that pressure.
So that thing where they put the tube up inside of you and then run the water up.
Amnio infusion? Because you wouldn't be able to get the tube up in there to. Now, amnio infusion. Hey, y'all. She had a great question. So there is something called amnio infusion that sometimes they'll do. And with amnio infusion, they take a catheter basically and they put it up. If you don't have enough amniotic fluid, they put a catheter up in there and they're basically flushing out your uterus to give some fluid. This can help prevent that because if you don't have enough fluid, it makes it more likely this would happen. So it could, but it won't help it once it's happened. So the other one we have, wait a minute, where's my shoulder dystocia? Well, darn it. So On uterine rupture, so your uterus can absolutely rupture from the pressure. It's uncommon. It's not as common as it sounds. But especially patients who have had previous cesarean sections or other abdominal surgeries would be more at risk. So symptoms you should know of a uterine rupture. So typically it's going to be very sharp pain. Contractions just stop all of a sudden. You can't have a muscle contracting if it's no longer intact. So contractions just immediately stop. And they'll start having pain in their upper back between their scapula. And it's referred pain because as their abdomen is filling up with blood because they've got an organ that just ruptured, it's going to rub up against that diaphragm and irritate it and start giving them upper back pain. Any questions? All right, take a break for like 10 minutes and then we'll come back and play. I mean, you can go home. A game. Ooh, what is that? Okay. All right. Let's do STDs for 100 and see what we get. All right. So which vaginal infection is characterized by itching and inflammation of the vulva along with white cottage cheese-like discharge? What's another name for it? There you go. Vaginal candida infection, candidiasis. You'll see it both ways. What do we choose to treat it with? Yep. You got it. Yes, ma'am. That's all right. Yeah. You're fine. But this is recorded where I've done tutoring with this as well on YouTube. Mm-hmm. And I even relabeled all the videos so they actually have titles instead of dates. So it could be miconazole, which is like your monostat, it's your topical vaginal solution that you use, or fluconazole, which, as y'all mentioned, that's the other name for diflucan, which is the oral form.
Okay, I would take pregnancy 100.
Pregnancy for 100. So let's see if you know this one. Nasal congestion, epistaxis, Chadwick sign. They're all related to vascular congestion caused by increases of what hormone? Nope. All that extra vascular flow that we get in our bodies. Nope. Are you sure it's not? It is estrogen. So what's the hormone of pregnancy? What did I mention is called the hormone of pregnancy? Progesterone. Y'all know that one, progesterone. So which hormone is detected in a pregnancy test? That's your human chorionic gonadotropin, aka HCG. So what temporary organ produces these hormones? Uh-uh. Y'all are overthinking this. The placenta. So the placenta is the only temporary endocrine organ in our body. It is the only organ that's there for a period of time and goes away when we don't need it anymore. So it truly is an organ because it produces hormones. Huh? Yeah, it's only there when you need it while the baby's there, and then it's birthed when you birth the baby. And then when you have a new pregnancy, you get a new placenta. No. So the placenta produces all three of those hormones. The HCG tells the placenta to produce the estrogen and progesterone.
Okay, wait a second. So we have estrogen and progesterone in our bodies already.
Correct.
When we go through menopause and stuff, we don't have a placenta in there then. So how?
No.
So where did the estrogen and progesterone?
So the ovaries produce this as well.
Okay, but
Under normal scenarios.
that makes sense.
Yeah. So to help with ovulation and things like that, you're producing estrogen by the ovaries. But to stimulate the levels we need to maintain a pregnancy, then the placenta takes over. Contraception. Let's jump on to 400. I love your confidence. It is important to teach patients that these classes of medications can decrease effectiveness of oral contraceptives. Antibiotics, that's one. There's 3 total. Nope, not steroids. Nope, that's a steroid.
It does. Now, correctives or something.
Anticonvulsants. So I talked about patients with seizures can't take oral contraceptives, and then barbiturates. Those are the 3 big categories.
So you don't take it with it, or you just double up?
You have to double up, which if you're talking about antibiotics that's temporary, then you're talking about doubling up. But if you're talking about something like an anticonvulsant that you take every day, then you just wouldn't be able to take oral contraceptives with it. All right. Which one? 100. All right. Maintaining temperature, allowing for fetal movement, allowing for symmetrical growth, preventing adherence of the amniotic sac to the fetus, providing cushioning. What would be the functions? And very good. So we talked about this a little bit last week. These are all functions of the amniotic fluid.
Same category, 500.
500. Let's jump on up. Consumption of what important nutrient will help prevent neural tube defects? Hey, wait a minute. That's not a 500 of them question. So what foods could we teach them to eat? Yes, green leafy. I think green leafy vegetables and chicken are the answer to everything, it seems like. So in this case, so lentils, green leafy vegetables, broccoli, avocado, your fortified juices and stuff like that will have extra folic acid, fortified grains. Contraception for 100. So what method is best to prevent STIs as well as pregnancy that's not abstinence? Very good. Y'all know that one. But the absolute best is abstinence. 500 pregnancy. So what is the recommended weight gain for a mom who has a normal BMI? 35. Very good. 25 to 35 pounds. If she's overweight, it's recommended to gain less, 15 to 25. If she's overweight, it's recommended to gain, if she's underweight, it's recommended to gain more, 28 to 40. Yes. If they're underweight. Yep. Yep.
A&P for 100.
A&P, let's see some A&P. So the symptom of this is most noted as dark brown prune juice vaginal bleeding. Dark brown or dark red, looks like prune juice. If you look at it on ultrasound, it looks like a cluster of grapes. Oh, that thing. It does. Well, one of the words does. So hydatiform or molar pregnancy, or gestational trophoblastic disease is the other name you'll hear it called. Flashcards. My daughter hates whenever my daughter says she can't remember something, then I recommend flashcards, and she hates me for it. Contraception. So this is often the first line of drug therapy for infertility because it helps stimulate ovulation. What is the name of a drug? I mentioned it a little last week or 2 weeks ago. It is very good. Clomiphene, which is the generic name for Clomid. Very good.
Don't forget to, are you using generic?
Yes, we always use generics because that's what you'll see on NCLEX is only generics. So we want to make sure you're prepared. That's right. Now in practice, I would recommend that y'all learn both because, and we saw it this weekend on one of the MARs, they had some drugs that were in trade names and some that were in generic names. But on NCLEX, they always use generics. A&P, let's run to the top. Complete cessation of menses for a full year would be called what? Menopause. Very, very good. So no unprotected sex until you've had no periods for a year. And even then, I think I'd be too scared.
STD 500.
Which one? 400? 500. These two STIs often appear similar. One has white or grayish discharge. The other has yellow or greenish discharge. And they both have a fishy odor. Nope. There you go. Trichomonas and bacterial vaginosis. And how are they treated? They're treated the same. That drug. There you go. Flagyl, aka metronidazole. That is what we want for both. There is. 500, our last 500. The danger signs of oral contraceptives identified by the acronym ACE. So what does A mean? Not that. It is headache. Abdominal pain. You are correct. Chest pain. Headache. Nope. What you see with? Eyes. Eye problems. And then S. Could be two things. So I is eye problems. E is eye problems, as in either blurry vision or double vision, and then S could be either speech disturbances or severe leg pain. Not what? Oh. All right, 200. Last one. So what method should be left in at least 6 hours, but no more than 24 hours, and should be used with a spermicide for maximum effectiveness? The diaphragm or the cervical cap. They're both that way, but we focused on the diaphragm. But either one. At least, and the sponge as well. The sponge should be left in at least 6 hours because you need it to block everything. Pregnancy, 200. So amenorrhea, fatigue, nausea, breast tenderness, increased urinary frequency, skin darkening. What category of signs of pregnancy are these? Presumptive, probable, or positive? You are correct. Say it with some gumption. You got this. These are all presumptive signs. So these are all signs that the woman would report. They're more vague, and they are things that she would tell you she has. Your probable are things that are more likely. They're more probable to be signs of pregnancy, and they're things you would observe, like a positive pregnancy test, for example. Yes. And then your positive signs of pregnancy are things that absolutely, without a doubt, there is nothing else that can explain them. What's that? Yeah, exactly. Fetal heart rate. That's a prime example. A&P 200. What is the purpose of the biophysical profile? Why would they do it? Yeah, to check the baby. So this gives us an idea, gives us a more objective idea of fetal well-being. So instead of just saying, oh, they're doing well or they're not doing well, this gives us a number. It gives us a score so we can really outline more objectively what we need to do. So what's a normal score? No, baby's going to die if you leave him in there with a score of 4. 10. It's a range. What to 10? 10's the best. Lord, y'all gonna have some not thriving babies. 8 to 10. Your score can only be 0 to 10, so. Oh, Lord. Fetal development, 200. So give me an average gestational age you think this could be. So in this fetus, lanugo coverage, wrinkled translucent skin, has brown fat, respiratory movements have begun, they have stronger quickening, which quickening is that feeling of movement, of fetal movement, and they're able to start opening their eyes. So around what gestational age do you think this would be? Like, give me a week. That is extremely close. 25 weeks. Good job. Excellent. Do what? Lanugo. So it's part of it. So lanugo will start to diminish as baby gets older. So in a very preterm baby, you'll see more lanugo, which is that downy covering, and then it slowly decreases as they get older.
I would say pregnancy
400. So a patient who reports eating non-nutritive items, what would they have? Very good. And it's most likely due to what when it occurs in pregnancy? You got it. Iron deficiency. See, y'all know something. Just a little. That's all right. We got a week. Last pregnancy. All right. So what 4 vaccines cannot be given during pregnancy or at least 1 month prior to pregnancy, but they can be given immediately after birth? Yeah, live vaccines. What's name 4? 3 of them are usually given all at the same time. MMR? No. Well, that's part of MMR. Yep. Yep, so measles, mumps, rubella, and varicella, they're all live vaccines, so we can't give them during pregnancy. But as soon as they pop that baby out, they can certainly get those immunizations, and usually they will encourage them to take them before they actually leave the hospital, so that way they make sure they get them. But another big teaching point, they should not conceive another baby within 30 days, which hopefully they just had a baby and they won't, but I mean, you know, things happen. I mean, some people start having sex in the hospital room while they are still there, just having a baby.
Yeah, and so after 9 months, they will come and bring another.
Yep, and then you got another one.
So STDs 200.
200, last 200. So antibiotic use, soaps, douching, intercourse, and hormonal changes with ovulation can all result in changes to what factor that would increase vaginal infections? See, y'all so smart. Your pH and your normal flora greatly affect some vaginal infections, like your BV and your Candida infections. 300. So what is the vascular composition of the fetal umbilical cord? How many veins and how many arteries? Yes, 2 arteries, 1 vein. So there's 2 ways you can remember this. AVA is probably the easiest one that most people think of, AVA. So you got artery, vein, artery. Or you can only have 1 valedictorian, so you only have 1 V, one vein. So which one carries unoxygenated blood? Are you sure? Are you just saying that because I said, are you sure? It is the artery. So when you think of most of your body, in most of your body, veins are what carry unoxygenated blood, right? Except for when you're talking about, for instance, your pulmonary artery carries unoxygenated blood because it's going from your heart to your lungs. So instead of thinking of unoxygenated versus oxygenated, think of arteries away. Arteries are always going away from you. So it's going away from your heart or away from your body. So the arteries are going away from baby. What's that? Oh. Oh, this one looks lonely. What kind of drug use should be asked about while obtaining a prenatal's history? What kind of drugs should you ask about? Very good, Rakita, all of them. Perfect. So sometimes people only think to ask about like illicit drugs or things like that, and they often forget to ask about over-the-counter drugs or herbal medications or all these things that sometimes people think that you might not think to ask about. So everything that there's a potential they could take that would either interfere with something else they're taking or interfere with their pregnancy, we want to ask them about. $300. The most effective method for prevention of STI transmission as well as pregnancy. You already gave me the answer earlier. It is bingo. Whoops. Well, I didn't mean to do that, but let's go to the next one. This STI is associated with a painless canker lesion at the site of exposure. You got it. Syphilis. And how do we treat syphilis? Penicillin. That's the one we give penicillin for. I don't know how it flipped to that one, but okay. Here, I'm going to fix that so it. 300. The best time to perform a breast self-exam is what time of the month? How long after your period? Yeah, about a week. So at about the end of your end of your period, I should say, or 1 week after it begins. Good job. All right. What's that? A week after it begins is at the end of it. At the end of your period, yes. So increased carbohydrate and decreased caffeine intake can help with symptoms of what menstrual disorder? Kind of. Yeah, you got it. I know what you're trying to say. Premenstrual dysphoric disorder. Your PMDD. All right, let's see how much math y'all know. Oh, go ahead. All right, so you have a patient that has an order to receive normal saline at 175 milliliters per hour. The nurse hangs a bag containing 1,000 mLs. How many hours will it take it until it needs to be replaced? So instead of you get a volume and a time and you're figuring out your rate, you're giving a rate and a volume and you need to figure out your time. Round to the 10th. Look at y'all. Y'all are brilliant. So it's really just, instead of doing volume over time, you do volume over the rate.
So in the real world, nurses pull out their phones for this type of stuff, right?
Sometimes. Yeah. I always carried a calculator in my pocket because sometimes it was easier than finding the app on my phone. But it is, and this is something we actually, most nurses use in practice. When you start your shift, for example, and you go in and you see how much fluid is left in your bag, and you're like, oh, based on this, I know in 3 hours my pump's going to beep off. I need to replace the bag. It helps you kind of manage your day instead of the pump yelling at you before you're ready to, go in there. And who's ready for round 2? I mean, we don't have to.
Yeah, we don't have to. I'm talking about. I'm talking about myself. Yeah, I'm just about myself.
Y'all are welcome to go. I figured y'all would want all the help you can, but.
No,
because I work 12-hour shift and all day at the car.
So anybody that wishes to stay, you're welcome to stay with me and do round 2, since you have an exam next week. But
I really thought you were joking. I didn't know that was a
no, I wasn't joking.
abnormal pregnancy 100.
Let's see.
Do you have more fragments off there?
Let me see. There might be some blank sheets up here.
I got them.
Oh, you got some? All right, 100. Maternal tachycardia is the most common adverse effect of which tocolytic medication that I mentioned, and it's not magnesium. It's one of them, right? Terbutaline. Terbutaline. L&D 100. Vaginal discharge along with increased intensity of contractions with ambulation would indicate true or false labor? True. Whoa, I gave you all the answers apparently. Shoot. So true labor. So the vaginal discharge would be a big clue. Usually with false labor, you're not going to have any vaginal discharge. And then the increased intensity with ambulation. So if with false labor, you would have no cervical changes if you check. Mm-hmm. You need to pull your mask up. Over. So no cervical changes. And with Braxton Hicks is how they describe it. So they describe it again as a painless tightening. Although if you've ever had them, they don't always feel like a painless tightening. And then they get better with ambulation. Symptom management. Not sex management. You're not the first one to say that either. That's why I had to point it out. Which one did you say? 100. So this is the best non-pharmacological method of pain management for back labor. Yes. Your sacral pressure, your sacral counter pressure. It's okay. You're not the first one.
That's normal LND 400.
All right. So what type of fetal heart rate pattern would be described as non-reassuring? It's related to uteroplacental insufficiency.
Yeah, late.
Very good. Late D cells. Y'all know that one. That one's the worst one. So what would be related to cord compression? The V one. What's the word? There you go. Perfect. Variable. So what is the primary nursing action with these? Turn her over. So that's the first thing you can do is turn her on her side. And what would accelerations indicate? Baby's okay. And a normal fetal heart rate? Look, y'all did fantastic on that. You do know something. Let's take the test now. Let's just get it over with. No, well, okay. Fine, I'll give you a week extension. Miscellaneous, 100. Y'all are just going across. I know what you're doing. These are methods to prevent complications of immobility in a patient who's bedridden. So what are some things we can do for people who are bedridden or impaired mobility or? Yes, turn them. Yes, SCDs, those are great. Yes, passive or active, whatever they can do or can't do. What's that? Yes. What about their breathing? What can we do to prevent them from getting pneumonia? Yeah, very good. Have them either use an incentive spirometer or even turn, cough, and deep breathe. So fiber and fluids, that will help prevent what? Constipation. active range of motion or passive range of motion if they can't do active range of motion, deep breathing or incentive spirometer, and also encouraging them to either interact with their family, have familiar objects at the bedside, because bed rest can cause depression as well. Now, COVID right now, we can't really encourage them to interact with their family, but
them frequently to prevent ulcers.
well, if they can turn themselves, then we don't have to. But this is more. Don't think of somebody who can't move. Think of somebody who has to stay in the bed, like with preeclampsia. But absolutely, if they can't move, you should definitely be turning them.
Can't that happen like early in their pregnancy too? So they're in bed for months.
Yeah. Like especially patients that have pre-existing cardiac abnormalities. Sometimes they're on bed rest their entire pregnancy. Miscellaneous 500. So too frequent or too long of contractions are called It is the uterine hyperstimulation. So what can you do about that? What's the first thing you can do about it? Stop the oxytocin, because more than likely they're having these ridiculously frequent contractions because they don't need as much oxytocin as they have. So stop the medication that's causing your problem. Oh, shoot. Well, we can go ahead and do that. I don't know why it keeps doing that when I click home. So here's your math on the final. Patient states her last normal menstrual period began on November 9th of 2020. So what would be her due dates?
August 16, 2021.
Is that everybody's consensus? You are correct. So there's two ways. I talked about adding 9 months and adding 7 days, which would give you the August 16th. Or you can do like the book where you subtract 3 months, add 1 year, whatever. So don't forget your year. August 16th, 2021. Look at y'all. Y'all are pros. I don't know why it keeps going back to the next, or going to the next question when I hit home. That's weird. Labor and delivery, 400. So this term describes the level of the presenting part of the fetus in relationship to the maternal ischial spine. So how far down they're coming down the birth canal. Station, they're pulling into the train station. So when is it positive or negative? So what's positive versus negative? Yeah, very good. So negative is above the ischial spines, meaning higher up in the birth canal. Positive is below. Baby is positively coming. Abnormal pregnancy, 200. So these are the diseases categorized as torch infections and can be problematic when contracted. So what's T? Oh.
Tachycardia.
Nope, these are infections. Nope. I'll give you O. O is other. You're welcome. H is herpes. Very good. What is R? I bet y'all might know what R is too. Rubella. So toxoplasmosis, rubella, cytomegalovirus, and herpes. Torch infections. L&D 200. These would be criteria in which a woman would be instructed to go to the hospital for suspected labor. Like what would be signs of true labor, essentially?
Regular contractions.
Yep.
And if she's looking, it's still like pain.
If they're how far apart is the, 5 minutes is usually kind of the cutoff. If her membranes rupture. Yep. So if her water break or she has rupture in membrane, she might as well go head to the hospital because you're not coming back from that. Contractions usually once they hit 5 minutes or less. If she starts noticing baby not moving as much, it could just be because babies typically start moving a little bit less approaching birth, but it could be there's a problem. And then if she has any kind of vaginal discharge. Yes, ma'am. Yes. So if we're not thinking labor and we're worried about babies not moving around, yes, your danger sign is less than 3 movements an hour. Yeah, you can try juice and see if baby moves around a little bit more, get up and walk, see if it stimulates, and if it doesn't, then she should go be seen. Yep, you got it. 300, abnormal pregnancy. So these two pieces of data would be the most important to collect from a pregnant woman complaining of headaches or blurry vision. So if she's got headaches or blurry vision, what are you thinking? Not blood sugar.
Hypertension.
So what do you want to check in a woman that's pregnant that has hypertension?
Protein in the urine and blood pressure.
There you go. Perfect. So checking the blood pressure because we're thinking hypertension with the headaches and blurry vision. And on top of that, we want to check for protein in the urine because she might have what? What is it called? Preeclampsia. Oh, see, it did it again. What in the world? It's glitching on me.
Pain and
Sorry. That's not funny. Dizziness and tingling of the hands can be symptoms associated with what improper breathing side effects? Y'all are never going to forget that one, are you? So what can we do to help with this?
Yes.
Have y'all ever told somebody to calm down? How well did that work for you?
It makes me more nervous.
So the best way when somebody is hyperventilating is to have them rebreathe in their carbon dioxide, so that way it will help decrease their pH. So one way we can get them a paper bag. That's why when people are having anxiety, they show you have you breathe into a paper bag. It actually does have a physical benefit. In the ER, sometimes when we have people that came in with anxiety and they said, I can't breathe, I need oxygen. We would take an oxygen mask and just not hook it up to the oxygen and put it on their face. It actually serves a physical benefit. One, it makes them think they're getting oxygen, which I know you're like, oh my God, that's deceitful. That's terrible. But it does actually have a physical purpose. It's that enclosed space that makes them breathe their CO2 back in and helps them. What's that? Right? See? There is a benefit. Yeah. Yep. Blood pressure and protein in the urine. I don't remember which one it was. Abnormal pregnancy, 500. So dehydration, weight loss, electrolyte imbalances, what are they significant for? Hyperemesis gravidarum, very good. Abnormal pregnancy, 400. Last one in this category. So macrosomia infants and polyhydramnios. What are you going to think? Big babies, which means mama may have diabetes, whether it be pre-existing or gestational.
We can't find this somewhere because my phone is dead.
What's that? I'm sorry?
Like we can't find this.
No. Exactly. Abnormal labor and delivery, 300. So an emergency situation where pain may radiate to the upper back between the scapula with inspiration. This is the last thing we talked about. Very good. Uterine rupture. Miscellaneous, 200. So what medications are used to stop preterm labor? There's 4.
Yeah. And magnesium sulfate.
It's not my time.
Yes, very good. It's not my time. Oops. Shoot. So indomethacin, nifedipine, mag sulfate, terbutaline. The biggest side effects, tachycardia, like I mentioned already with the terbutaline, and it can also cause maternal it can drop her potassium levels too, especially the terbutaline. L&D for 300. So the primary nursing intervention for any acutely unstable patient, such as, for example, when delivery is imminent. So what is an NCLEX type answer? You have a patient who's about to give birth. What would you do? Yeah, well, so when you're talking about emergency situations, NCLEX is very big on making sure you don't leave the patient. So for example, if you had a situation, say the patient's having a seizure, what do you do? If you have an answer of go to the nurse's station and get help, that's never going to be the answer, because it's always looking for, you're not leaving the patient alone. You're not having other people do your work, but you do need help. So staying with them, calling for help, that kind of stuff. And that's with any emergency. That's one of those NCLEX tips they like to use. 500 labor and delivery. So these complications would result in contraindications for induction as well as vaginal. So what's some reasons we would not want to induce or have a vaginal delivery? Yes. Yes.
The long way part of the vertical.
Oh, yep. If they've had a vertical incision, if baby's in a transverse lie, meaning they're lying sideways, we're not inducing labor for that, because baby ain't coming out that way unless they move. So if they have a complete placenta previa where that placenta is covering the cervix, if they have that prolapsed cord, so if that cord is down next to baby's head, we're certainly not going to try and push baby further down. That abnormal fetal presentation, that's meaning where they're not, coming down head first. Good job. Which one? Oh, the last 200. The primary nursing intervention when a prolapsed umbilical cord is suspected. Push it back up. So there's a couple things you can do. So you can put them in Trendelenburg position, or you can even put them on their hands and knees, because it opens up that pelvic outlet. But the other one is also going to be to take your hand, hopefully a sterile gloved hand, and push baby's head up to relieve some of the pressure on the cord. And the most likely time that this is going to occur, like what event usually happens right before?
Oh, the rupture.
Yeah. So anytime there's rupture of membranes, whether it's artificial with the amniotomy or if it's spontaneous where she naturally ruptures her membranes, it's the most likely time for it to occur. Because all that water flush it out. Which one? You don't know. I don't know. 300. The RH presentation of mother and baby that could potentially result in isoimmunization if mama is what?
No, negative.
There you go. So mom's negative and baby is positive. So what drug could we give to mom? There you go. Rogam or RH immune globulin. And when do we give it? You got it. 28 weeks and then within 72 hours afterwards. Good job.
So any RH negative, not just O negative?
Yeah, any RH negative. Whether you're AB negative, B negative, A negative, all negative. Oh, 100. All right, so mag sulfate is often used to prevent what complication of preeclampsia? Why would we give mag sulfate if they have preeclampsia? It's not for blood pressure. Seizures, very good. Prevents seizures or eclampsia, and the characteristic symptom, convulsions and coma.
So SX stands for symptom?
Yes, SX stands for symptoms.
had a seizure, or they have to have seizures before they get
What?
Do you give the magnesium sulfate before they have a seizure as a preventative measure? Or
Yes. Hopefully you're getting it to them before they ever have a seizure and you keep them from having it. But if they start having seizures, you can give it then too. 300. The most common adverse effect after a spinal or epidural block. No. After the insertion of it.
You took hypotension.
Hypotension. So what can we do about that? There's two things we can do if they drop their blood pressure. Fluids and turn them on their side.
Abnormal for 400.
400. So these characteristics of amniotic fluid would be considered concerning and should be reported. What would be abnormal? Meconium. Odor. Very good. Correct. So if it's like a watery green, which would indicate meconium, or if it's cloudy white or yellow, or if it has a bad odor, those are all indications of infection. Abnormal for 5. Immediate drying of the newborn after birth prevents what complication? We didn't talk quite about this one. Exactly. It prevents hypothermia. We actually talked about this at pre-semester. So it's very important that they dry the baby off right away because evaporation can cause hypothermia and cold stress to baby. One of the first things they do, once they know baby's breathing, they wipe them off.
Okay, page 500.
500. So what pharmacological method appeals to the gate control theory of pain? Do y'all remember that from fundamentals?
Yeah, you just like mentioned these like special odors for
Not gate control theory. Massage. Massage. Gate control. All right. So what medication is used as a reversal agent for opioids? What's the generic name? No. Naloxone. So what is the most severe complication of opioid overdose? Yeah, respiratory depression. Very good. What's the most common? Almost everybody who takes an opioid gets this side effect. Constipation. Very good. All right. Study hard. I will see y'all next week at 5:30 on the dot.